one of the general surgeons that come out here from Harrisburg. My specialty is colon and rectal, which would be colonoscopies as the first stage. If we find anything, I'd be the one to treat it, take it out, do surgery, whatever we need to do, follow-ups along those lines. Who's over 50 in the room? Who's had a colonoscopy? Yeah? Are you? You, man? Why not? What's that mean? Why not? You afraid? You don't want to do it? Why haven't you had one? You think it's only an exit only? Exit only? Yeah? Okay. Alright. As you can see, it might be an exit only, but if we don't go up there with this little tiny scope, then you might have a lot more serious problems going on. Okay? So colon cancer is the second leading cause of cancer deaths in America. Male and female, it's equal. Doesn't affect males more than females. Affects everyone equally. So lung cancer is number one, colon cancer is number two. Both of which, if you scan and you can do it, they can be prevented. So that's why we do colonoscopies. It prevents colon cancer. Or if we find something, we can catch it early, and it's highly curable in the early stages. So there's 4 stages, 1 through 4. 1 is curable up to 92% if you catch it early. But if you go to the 4th stage, where it's in your liver or somewhere else in your body, it's less than 25% curable. So you get these things done early when you're supposed to. You can either prevent it or treat it. So polyps can turn into colon cancer. So that's the way you prevent it. So if you go in there and you see a polyp, we can remove it completely. We send it away. If there's no cancer in it, then we just do another surveillance in X amount of years, depending on the pathology we see. Now, if there's a cancer in there, then we biopsy, send it away, and then we talk about doing surgery. Okay, so the only way to get rid of the cancer is surgery. But if there's no cancer, there's polyps, or it's a normal colonoscopy, we just keep doing the colonoscopies as a routine thing to prevent any cancer from coming. A polyp, like I said, can turn into cancer, and it usually takes about 7 years on average for it to turn into a cancer. So that's why you always hear, mostly 5 to 10 years for screenings if you do have polyps or something. But they can be fast, okay? And along those lines, colon cancer, there is a small genetic possibility. So if you have someone in your family who has colon cancer or has had it or had polyps, you are at higher risk, but it's only a 25% risk. Most cancers nowadays are sporadic. It's just they don't know why they happen, and they are becoming more and more frequent. Unfortunately, colon cancer is it's on the rise in those under 50, and they're the population that's not being screened because the insurances won't pay for it. So if you're over 50, your insurance will pay for it. Medicare, any of the commercial insurances. Now it gets a little dicey if we find a polyp. Some insurances then require you to pay a co-insurance or a copay because it's not diagnostic, it's not treatable. It's now treating, but that's something you deal with. Obviously, I'm not going to go in there and you say, well, I don't want to pay anything, so if you see a polyp, just let it go because I'm not paying my insurance. I mean, that's pretty dumb to do that. The reason we're going in there is to prevent cancer from happening. Now, that copay or co-insurance you have at that point is a lot cheaper than what it would be for a whole hospital bill for the surgery and the chemotherapy and everything after if you do end up having cancer. So it's something to keep in mind. So those who are at highest risk are those over 50, those with a family history, either of colon cancer or polyps. So if you have a family history of polyps, you should get screened starting at 45 instead of 50. If you have a family member with colon cancer, you should start at 45 unless they were younger than 50, then it's 10 years before that time. So say somebody in your family had it at 49, first degree relative, father, brother, sister, mother, you then get screened at 39, and every 5 years unless there's other pathology. Okay? So if we go in there and we don't find anything, it's usually 10 years unless you're high risk, then it's 5 years. If we go in there and find 1 or 2 polyps, it might be 5 years. If we find 6, 7 polyps, depending on the pathology of the polyp, it might be 3 years. Sometimes it's 1 year, depending if there's a bunch of polyps and we want to keep a close eye on it, or the one polyp looked real ugly, sort of like this one here. That's not cancer, but it's ugly, and it probably could have turned into cancer sooner than later. All right, so just because you have one, you won't be having one every year. On average, it is 10 years. Sometimes sooner, unless you have problems. So most people say, for those who've had one, will probably agree that the worst part about this is probably the prep. Agree? And that's just because you're giving yourself diarrhea. So you sit down on the day before your procedure, about 3 in the afternoon, you mix a bottle of Miralax in with Gatorade, 64 ounces of Gatorade, and just drink it until you shoot your brains out. And then you go to sleep. Hopefully you can sleep and you're not up all night going to the bathroom. Come to the hospital the day of. The nurses will put an IV in your hand. We go back to the room. You lay on your side. You're not knocked out, so no breathing tubes, no general anesthetic like you get your gallbladder or appendix removed. They put the medicine through your IV. You go to sleep. You're in a deep sleep. You won't feel or remember anything. Okay. I stick the camera in the backside. This is the camera. It's pretty long because your colon, here's your rectum, goes up, across, and down again. Okay, so we have to get it around there. Some people have floppy extra colon, and we have to go zigzag around. Some people are straightforward. But it's about the size of my finger, okay, so it's not very big. Again, you're not going to feel anything or remember it because you're not passed out. And we can do most of the work through the tip of it. There's a light on it. There's ports in order to put a grasper out there and pinch and remove. We can snare. Yeah, it's a little lasso that we throw, like we put around the polyp and we pinch it and we use some heat and we pinch it off and remove it completely. So, that's if we find a polyp. If we find anything else, like there's inflammation or, something that just doesn't look right, we can biopsy and send it away. And this way we have a baseline and we can see, what we're dealing with. So that's the bad findings on a colonoscopy. A bunch of polyps, precancerous polyps, colon cancer. Now there's other stuff that we can find in a colonoscopy that will help you manage, what you need to know in the future. So some of these pictures that we have, these are actually colonoscopy pictures that we've taken. So there's a thing called diverticulosis. You might have heard of diverticulitis or inflammation or colitis of the bowel. There's multiple types of that, but diverticulosis is the most common. Most Americans have it, especially by age 50, and that's because our diet is piss poor in fiber. Everything we eat now is processed, fiber stripped out of it, all the grains and everything like that. So what these are is where the blood vessels are in the bowel wall, there are little pockets, okay? And because we have low fiber in our diet, the stool isn't bulky enough to go through there, so little pieces of the stool pinch off and block those little pockets. And when they block those pockets, they become inflamed and they can rupture or just get irritated. Best case scenario, you're treated with antibiotics at home, you get better in a few days. Worst case scenario, you'll be rushed to the operating room because you have a big hole in your colon and you have to end up with a colostomy bag. Okay? Temporary, but that's the worst case scenario. There's a general spectrum in between there, so the oral antibiotics, IV antibiotics in the hospital, and then the surgery. Okay.
You said red meat's bad for that?
Not necessarily for that, but red meat is bad for colon cancer now, is what they're saying. So they're not saying don't eat red meat, but they're just saying eat it in moderation. So don't go and eat it every day of the week. And they're actually including pork in there, even though they don't say pork's the other white meat, they're actually including that as red meat. So, moderation meaning once a week, if that, maybe even less than that, can help decrease your risk of colon cancer. But not necessarily diverticulosis. Now, fiber, obviously there's no fiber in meat, so increasing your fiber will help prevent any further diverticulosis and prevent the diverticulitis. Okay, you won't cure it by eating the fiber, but you'll prevent any inflammation of that disease. And that's because it keeps your stool bulky, so there's no little stool balls falling off and blocking those things, causing the inflammation. In addition to the diverticulosis, you can find just a mass, which could be a cancer, it could just be an outgrowth, which could, be nothing. It's just how your tissue in your colon has overgrown. What else can we find in there? Foreign bodies. Seen that. You can use your imagination as to what it's not, okay? Either by swallowed or put in. And, what else have we found?
Baby? guys are thinking way out of control.
Any money in your imagination?
Maybe put
Hey, so if you're one of them off, right?
Yeah.
That means it's got to come the whole way out, and then you got to go back in again.
Well, sometimes we can suck it out to these channels. So these polyps, they look pretty big because we're right up in front of it and it's magnified, but they're probably not as big as what they look here. So a lot of them can be sucked out through that port right there, which is, they're less than a centimeter, so it's not very big. Most polyps are less than a centimeter. But sometimes, like you said, yeah, if they're too big and they can't be sucked out, we try to hold on to it with the suction and go all the way out, and hopefully we don't lose it and have to spend time. And that's one thing that can take a while with these things is we have to find these. It takes time to do. But no, that's a good question. Not all of them, they don't look this big. They're not actually this big when they come out. I mean, they're really smaller than my finger, and they just look magnified and look big. But, and for small bites, this one here is the cancer. You can see it's how it's eroded and all bloody and everything like that. That we would just take little bites and easily fit through the scope and send that away to that pathology. Sometimes we take them out piecemeal so we can get them out too because they're too big. But no, that's a good question.
Which, because they're so small, that's why the prep is important.
Yeah.
Because any stool in there, every time we find a little tiny one, I'm just like, geez, like how many people that didn't prep out completely did we miss one of those little tiny guys that 5 years later it's not so tiny.
So that's a good point with the prep. You can see down here, there's 4 prep, and that's not a mass. That's solid stool still in there. Okay. And I can't suck solid stool out through this little. And you're going to start eating now.
I've got no problem with that. He'll eat through it.
And that's the problem. When there's stool in there, you can't suck that out, okay? And that decreases the probability of me finding anything, especially if it's small, like Jen just said, okay? So the prep is important, okay? Like I mentioned before, it's Miralax in Gatorade. It's a lot of fluid, and it doesn't have to be Gatorade. You can do whatever your drink of choice is. I just say not to use your favorite drink because you might not like it after that because you're associated with colonoscopy. I've been asked beer, even though it's a clear liquid, is not a good prep because then you get dehydrated. But as long as you can see through it, you can use that as part of your prep. Okay. And then if the prep's good and it's just liquid left in there, I can suck the liquid out. But anything there's any chunks or anything like that, then it's too hard to clean out. And then we have to do it all over again because it wasn't good enough the first time. You don't want to be left with a polyp hiding in all that extra stool. Okay.
How long does it take?
The prep, it's written for over 3 hours.
I mean,
But it's 1 day, no food.
for this.
I'll get to that in a second. Hold on. So the day of the prep, when you wake up, don't think that, I can eat till it's 4 a.m. and it'll be out of my system by the time the prep starts or by the next day. It's not how the prep works. The prep doesn't push things through. It draws water in, giving you the urge to go with diarrhea. So it's not like if you ate something at 4 o'clock, all that stuff you drink is going to push it through fast. It's not how it works. It gets sucked up and then pushes through the colon. So that's one big misconception people think is, I'm going to drink 64 ounces of fluid, so it's going to be through me if I push all that food through. That's not how it works. So listen to us when we say, when you wake up, do nothing but liquids the day of the procedure plus the prep. And you can take your pills and stuff like that, but no solid food. Because we'll see it. When we get in there, we know who's eating and who hasn't. Even if you tell us you have eaten. The colonoscopy itself varies. Most 20 minutes to 45. Again, you're sleeping, that's nothing for you. Everyone says it's the best nap of their life. You wake up and you're just passing gas. But some people are more torturous. Their colons flip around. Most of the time, skinny women are the worst because they have no fat to, sag the colon down, and they're just really fixed in there, and getting around those turns are hard. And if we find a bunch of polyps, it takes time because of the orientation and twisting of the scope, and getting it lined up and getting it out, and make sure we have everything. Everyone's different. Sometimes they go up to an hour, but again, you're sleeping. It's worse for your family who's waiting for you, saying, when are we going to go home? Once it's over, you wake up, go to the recovery room, cast gas, and you eat, and you go home. You can't drive for 24 hours or operate machinery because you're under an influence of a drug. And if you get pulled over, you can get a DUI. So that's one big important thing. about this. Any questions
I think bigger your finger, huh?
about that, right?
Oh, yeah?
Yeah.
Uh-oh.
I didn't believe him when he said that, so I had to hold it up, and I'm like, yeah, I mean, a guy's finger is how big it is.
Sure.
What do you think now? Is it still an out only, or do you think it's a good thing to do?
You'll make an appointment now, aren't you?
I don't know.
It is something like 6 months ago.
Like that? No.
It was not that.
Yeah.
How often should you have that done?
It all depends on what we find. If you have a family history,
My doctor told me 10 years.
if you have nothing in there, it's 10 years. Now, if you have someone in your family who's had cancer, 35 years. But it all depends on what type of what we find.
My older brother did here just a few months ago.
You had colon cancer? So yeah, you would be, if we find nothing,
He had no symptoms, that's one.
yeah. You don't have symptoms until it's too late. Okay? You know, if a mass or a cancer becomes large, then one of the symptoms is it just blocks everything off and you can't go. That's one big thing is I can't move my bowels, or they're not the same, they're thin like a pencil, or they're black or tarry. Some people might have some blood, but a lot of people just chalk it off, well, I have some hemorrhoids, I was trained to go, and it's nothing. But, in reality, it could be something up higher. Polyps themselves can be, but so can cancer, so you don't know. Now, there are all these stool tests out there that, your doctor might say, send a stool sample in. But if it's positive for blood, all that means you need to go and get a colonoscopy. So it doesn't replace the colonoscopy, but it helps gauge the need to have one. There's a new one out there that tests the DNA in the stool for cancer. If it's positive, you still have to have the colonoscopy. So if insurance covers it, that's great. But you still need to have the colonoscopy to find it and identify where it is. Because you can't do surgery on the colon if we don't know where we're coming
So
from.
what you're saying, all the testing you do over the counter, so to speak, doesn't replace the colon.
Correct. All that will do is say you definitely need one.
So you're kind of misleading it, so to speak.
It's not misleading, especially if you're going 10 years in between and they say test your stool every year for some blood, and you were negative for 3 years and all of a sudden you have something, and that would say, hey, I need to go in there sooner than later to get another scope, because a polyp can pop up in that time, and it needs to be taken
What
care
I'm
of.
getting down somewhere in these ads they have on TV, they should put in there, you need to go if you,
It might in the fine print, like in it, down below, but obviously these companies are trying to sell their product in
Yeah.
case. But it doesn't replace this at all, and that's what your doctor who's going to order that should tell you. Now, if this comes back, we then have to go and do further work on it. So I mean, that's the ad's not going to probably go out there and say it because they want the money, but or your insurance is going to.
that's what something the doctor put it on. Negotiate.
Yeah.
So if there's blood in your stool, that's a concern?
It can be. It can be. Like I said earlier, colon cancer is on the rise in those less than 50. So usually, we would say, you're 35, you have some blood in your stool, it could just be hemorrhoids, we'll see.
That was my question.
And we look for that in the office, especially the younger patients. Like if we see hemorrhoids, we'll treat them or remove them and say, okay, let's see how it gets. But if it's persistent, then we want to take it and do a colonoscopy. I tend to jump a little bit sooner to the colonoscopy just because I've seen patients younger and younger and have colon cancer. Unfortunately, if you're 35 and you have blood in your stool, we have to use that as a code, and you're going to end up paying co-pays and stuff like that. So it's not going to be, it's going to be partially covered, but not completely covered by insurance. Now, over 50, we use a code of screening or personal history, family history, and we can get it covered by the insurance. So, again, the cost shouldn't defer you from wanting to have it done, because the cost of having cancer and all that stuff later, let it go, can be much more, but it'd be too late in that sense.
Hey, we gotta let our insurance company know that we're gonna go into something like that now, or no? You got a call? Get a call, get a heads up.
Oh,
Yeah. Okay, they put it in.
Did you?
Oh, man,
why not if they're gonna pay for it? If it's
Well,
not-
yeah, if it's free.
I would
I mean,
think it's pre-authorized, like they would probably do the authorization through the
I
hospital.
don't think they. I
The
don't think
authorization
you
would
need
come
to.
through.
You know, you're gonna want your red meat.
Like it's like a mammogram.
Once they
And
would
we don't call
turn,
and ask about
Avoid
the
fatty
mammogram.
foods.
once you would get into the office and it said that you need this, it goes, and that starts the process, and it'll contact the insurance company, and they'll do all the authorization. They do all of that authorization for you.
But you do get wellness points if you get one
I
done.
know.
25.
25 levels.
25, what do you gotta have, what do you gotta,
That was yours.
what do you gotta have
That's
for proof?
What?
What do you gotta have for proof?
Bring in the pictures.
I probably do that, you get the pictures, don't
If I take them, I don't know what
you? You used to, I did my last.
I would, you could just bring a doctor's note.
You get it. I can send you home with a piece of paper that says you had it with your diagnosis, or your bill.
Yeah.
Yeah, I'll bring one. Still got my bill, so I can pay it.
You can still bring it in, Carl.
Only you, Richard,
Better than me?
or me.
Honestly, I've never gone through one, but from what everyone tells me, it's not that bad.
You're standing there talking about it, you never
Exactly.
have.
Who's going to do mine? I can't do my own.
It's not.
I don't
Why
mind.
is 50 the magic number? Why?
Back in the day when they came up with this task force came up with the number, they found that the majority of patients who had colon cancer were above the age of 50. Okay, so along those numbers, so 50 to 75 is the age for screening colonoscopies. So the magic number then becomes 75. So after 75, it's a case-by-case basis. So if you have polyps and you're in good health, then you can undergo. They recommend undergoing a colonoscopy after 75. Now, and the reason they do that is because life expectancy from dying of something else other than colon cancer is greater at age 75. So they say there's no reason to do it. But if you're a healthy person, have no other major medical problems, why not get it done? Fine, if you have colon cancer, you can last another 10, 15, 20 years, why not? Versus just letting it eat away, and it's not a good way to go. Being obstructed by
I think
cancer.
that's why a lot of people put it off, they're afraid they might find something.
Oh, yeah. But it's easier that way than
Yeah.
having to deal with the cancer. Or you come in with perforation, meaning the cancer blocks everything and everything just blows out in front of it. And then you have a bag. Because if we can do the surgery electively, the odds of having a colostomy bag is much less. But if we have to do it emergently, it's 95%. And then, who knows if you're definitely going to get that reversed. So you might be living with that. So that's another reason.
Work, how much you
Carl, do this thing with
Yeah. So they told me do them on Mondays, though.
I do them on Monday. The other surgeon does them on
Take
Tuesday.
two.
I'm doing them on Tuesday.
Dr. Riggle does them on Tuesday, I do them on Mondays.
So I have to have Monday and Tuesday both off.
Yeah, that's your right.
I miss one day of work.
You missed Monday then?
One day.
One day of work.
Yeah, because you do the prep
They
for
do them
me.
on there 'cause they don't want to ruin your weekend.
It's Sunday afternoon. It's not all week.
Well, it's all day Sunday, there's no food.
Yeah.
It's not good if you have a Super Bowl party.
Right.
Say, what kind of doctor are you?
Just a regular physician or your
No, I'm a surgeon.
Just a surgeon. That does this.
Huh?
What's it called?
Colonoscopy.
Yeah, does it start with an E?
Colonoscopy.
oh, you mean the type of doctor?
Yeah.
No, I'm a colorectal surgeon.
You might be thinking gastroenterologist.
Gastroenterologist. That's a GI doctor. That's a medical doctor. They do the scopes, but they don't do the surgery afterwards.
You guys do hemorrhoid surgery as well?
Hemorrhoid surgery? Yeah.
How do you do that? Cut or laser?
If it's an internal hemorrhoid, we can do it in the office with a rubber band because there's no pain fibers up there. If it's an external hemorrhoid, then it's cut, unfortunately.
Oh.
And that's not fun. I try not to do them because it's too
I just started the
frequent.
laser surgery.
Yeah, there's a laser versus the rubber banding. I like the rubber banding better. I think it works better. But no, that's done in the office. It's a little pinch and a little uncomfortable, but other than that, you won't even notice it. It falls off. It's sort of like the rubber bands that kids put on their braces. It's that small. We stretch it out, put it over the hemorrhoid, and it just strangulates it and falls off.
Like we used to do the bulls on the phone.
Yeah.
Time to go.
All right.
Thank you very much.
No problem.